screen, and there we are. Okay, all right. Hello, everyone. My name is Swarnima. I'm leading product at Gytree, which is a women's health companion, an online clinic for women's health, for total care for women, be it gynecology, nutrition, or mental health. And today, as part of the Femtech Next conference, the conversation we are very, very glad to have with Dr. Sakshi, Dr. Vimee, and Mridu Gupta is about personalizing healthcare and why healthcare urgently needs a gender lens. Now, if we just go back into the pages of history of healthcare, it was only in 1990 that it was discovered that every cell in our body has a sex, which is a game changer, which basically means that healthcare and clinical trials and the medicine that have been just peddled in a gender agnostic way might not be the best way forward. It was only in the 1990s that the National Institutes of Health made it mandatory that women must be part of medical trials. And 1990 is very recent. There is a ton of research that is now being done, which shows that women's pain is not taken very seriously. More women are told that their health issues are psychosomatic in nature, etc., etc. And we see that more and more self advocacy groups are talking about medical gaslighting and so much more. So today we're going to deep dive on these aspects a little bit and talk about when we say personalized healthcare, what do we mean by that, and why we think that the era of gender agnostic healthcare is long gone. And now healthcare has to service the end consumer in a personalized and focused way. And there couldn't be a better group of people to talk about this. We've got Dr. Sakshi, Dr. Vimee, and Mridu. And I'll let them introduce themselves and talk a little bit about the stellar work that they're doing that we can all learn from in an intersectional way. So, Dr. Sakshi, let me start with you. We'd love to hear a little bit about your work, especially on healthcare advocacy for trans persons. And needless to say, it's underserved. We'd love to little bit hear about what work you're doing, and we'll take the conversation from there.
Thank you, Swarnima. I'm really glad to be here. I'm Sakshi Mamgain. I am a practicing physician. I am also an advocate for queer and trans health. I personally also identify as queer. I think that had a major impact on why we started out with the work that we are currently doing. Like right after med school, I was in a government setup in Delhi, and just hordes of patients would come in, and they would just swarm in. And throughout that year that I was there, it was just a little icky for me that not one patient who walked in identified themselves as trans, because whenever I would take their demographics, I would ask for their name, their age, and the gender that they identified as, and it was always just male or female. Um, Funny, I mean, ironic enough that I was also working in the burns and plastic surgery department. Uh, After that, so the only instance when a trans woman approached me was when she had to get a medical legal certificate made because she was abused on the streets, and that just sort of struck me in like a really, really bad light. Like also
Yeah.
because I identify as queer, and I had medical acumen backing me. So I just started reading up a bit, and turns out like not that there is a lot of data um, when it comes to Indian literature or the like the subcontinent. But I started reading up back then on the U.S. Transgender Survey of 2015, and that showed that most trans folks don't visit hospital facilities or seek medical care because they're so apprehensive of the negative treatment that they might encounter. Like just the apprehension is enough to stop them from accessing these spaces. So that was just like it just it hurt way too much to exist in both those spaces, in both the LGBTQIA plus community and in the medical space, in the medical fraternity here. So I just felt like there was something that needed to be done, and that is how UT was born. We have a little baby organization that started out 2 years ago. It stands for UT, which is United for Transgender Health. We mainly and mostly work in sensitization and creating more awareness when it comes to doctors, when it comes to medical students. So we host workshops and generally what we're trying to do is have healthy conversations around things that have any sort of stigma or any sort of taboo associated with them. So be it just the identity of being trans or queer or periods or sex or anything at all. We just want to be talking about it.
Absolutely. I think one of the things that you mentioned, which is, I think, a recurring theme, is going to be a recurring theme in the conversation, which is about the question of apprehension. An apprehension of something which should not be a part of healthcare, which is judgment, which is not getting the right treatment. So, coming to apprehension, I mean, Mridu, I'll come over to you. You have worked extensively in cervical cancer through your organization. I'll let you introduce that, but I would like for you to touch a little bit upon this apprehension to get tested, this apprehension to go to the doctor, because I remember this doctor, who had once said that sometimes people fear the diagnosis more than the illness itself. And I'm sure this is something you've come across a lot in your line of work. So would love to hear about what, you're doing with your organization.
Thank you, Swarnima. I am really moved to hear what you're doing, Dr. Sakshi. It was wonderful to hear that. There is a lot that I still have to learn in this space as well. So it's nice to see you speaking with all this passion and everything. And I think these are personal experiences that actually bring us into this. So for me, I've been in the development sector for the last 28 years, but I lost my mother to cancer, which is where my attention moved to cancer. And then I started to study about it and read about it while she had cancer. And then I realized that there were just so many things in her journey that we could have probably seen much earlier. We
Yeah,
would have been able to pick it up much earlier if we knew what we were looking for, you know.
that's right.
So when I lost my mother and we were talking to the doctors and there were other people who had lost their wives or their mothers and whatever, we realized that there are some areas of cancer that are completely preventable, and all over the world they are on their way to prevent it. But in India, we're not even talking about it. Again, they are
Mm.
related to sexual infections. They are related to women and the gynae system, and you know how women have their hesitation or they don't talk about it, and especially in rural India. So
Yeah,
we started to work on cervical cancer. We were told that that is something that we must do because even from a doctor's perspective, they say that by the time women come, they are showing last stage symptoms and
yeah,
it's too late to do anything. And it's a cancer that is 100% preventable if we can catch it early. Even
yeah,
for the doctors, they said it's a waste of human life that, you know,
yeah.
these women come in so late. So we started with cervical cancer.
Mm.
And once we were in the field, we realized it's a lot more than just telling them that you need to be screened. There are social
Mm.
barriers, there are cultural barriers, there are their own mindsets that, you know, that are hardwired into women over
Mhm.
generations. There was just so much that we had to battle in public health, especially in rural India, but even in urban India. So I don't think it is about education or ignorance. It's just something that is built into our culture and our system, and
Mm.
we can discuss it as we go forward. But this we have seen a lot. And then
Mhm.
we moved from cervical cancer to breast cancer, and now we are talking about oral cancer as well, because we've realized that for women, they just need more information, they need more persuasion. We need to break just too many barriers. So it's not
Absolutely.
only about cervical cancer, it's about more. So that's how so I when I set up capid with other trustees like Mr. Bharatram and Alok and Mr. Nagpal, this was in 2014. We set up Cancer Awareness Prevention and Early Detection Trust. We started with creating awareness, but then we realized access availability of screening was in India was very, very low in uh, rural India. So we started with screening as well. And now we've moved to patient navigation and we work with the government to strengthen the healthcare delivery system. So that's where we are at present.
Yeah.
And that's what CAPIT is doing. And we can discuss it more
Yeah.
later.
Absolutely. No, I think what you just mentioned about the fact that there is, the diagnosis and the screening, that's always a big challenge. And it's almost as if, women are just losing their lives. It's a waste, right? Speaking of delayed diagnosis, one of the very very common conditions that we see very much in India, like I call it one of the most debilitating illnesses or conditions in the country that no one has heard of, and that is endometriosis. so many women are getting misdiagnosed as something else, maybe IBD or Crohn's or something or the other, when they actually might have endometriosis. And Dr. Vimee, I would love to hear about. I know that you're an expert in endometriosis excision, but what we would love to know is the work that you're doing as part of your initiative to really elevate the conversation around endometriosis awareness. And while we hear of PCOS and everything quite a bit, endometriosis is something that somehow gets hidden, even though it's almost just as common. If so we'd love to hear a little bit about the initiative then.
Yeah, thank you so much, Swarnima, first of all, for having me here. And I would like to congratulate Dr. Sakshi and Mridu for the commendable work they are doing. Coming to endometriosis, yes, it is as common as diabetes, but the attention it does not get.
Yeah.
So, why it does not get is the question. As Mridu said, women are wired like that. They have been told for years together, your pain during period is normal. Now these women keep on suffering in silence, and it is very difficult to get that out of their minds that pain during period is not normal, because their mothers told them, their grandmothers told them, I
Yeah.
used to have pain when I got married, when I had children, it was fine. And so you wait for your marriage, you wait for your childbearing, and you'll be fine. These women have pain during defecation, these women have pain during sex, but they do not come out because they have been told for years together that your pain is normal.
Yeah.
So, uh, and also it's because I think it does not get attention because it has been gendered. It has
Yes.
always been told it is a female's disease. So, had it been a male disease, wouldn't it have got it attention? So, it has been gendered for so long that it is very difficult to change the scenario. So, we are working hard towards that. We have been creating awareness through social media and some other channels, so that was also the purpose. We have been doing it for last 2 3 years, but I and one more patient advocate is there. She is endometriosis survivor, underwent 4 5 surgeries, so we together were raising a lot of awareness for last 3 years. But then I thought this should have a name, otherwise our all efforts get lost. Until unless you
Yeah.
have an organization or an entity working towards some goal, it becomes very difficult to show what you are doing, or if you want to change some policy, it becomes very difficult. So that's how the Endometriosis Foundation of India was born recently. It's in infancy. We have started doing awareness programs with the schools, with organizations, and also it sensitizes patients as well as it sensitizes public, families, and doctors. Now, endometriosis needs awareness for doctors as well, because even the patients who come to us, as you said, gaslighting is very prevalent in endometriosis. Patients, even doctors tell them that pain is normal, it is all in your head.
Yeah.
You look normal, nothing is there, go get married. They give them a matrimony address as well. So it is so painful. And they keep running around with 6 7 doctors consultation, and by the time it is diagnosed, it takes 7 to 10 years,
Yes.
and the damage is already done. It mainly affects ovaries, but it also affects bowel, bladder, ureter. Silent kidney loss is very common. Obstructive bowel symptoms are very common. So these patients land up in trouble. These things need a lot of attention. So gynecologists, it also needs attention at the medical school level,
Yeah.
because our teaching, when I was studying, the teaching was not the way I treat endometriosis today. So the teaching has to change from that level. I will tell you that when I was in my gynecology residency, when I was studying it, so my teacher who was teaching endometriosis chapter that day, he said, if you get an endometriosis patient, you send it to your enemy, because you can never treat it. So excision word we never heard during our residency. So when I came into practice, I saw patients were suffering. Their pain was not going away by removing the cyst. The recurrence was very high. It was not a recurrence actually. It was a residual disease which was never removed.
Yeah.
Then I started going into deeper into the subject. Then I came across the pioneers who started excision surgeries, and they started removing the disease. And I started doing that in my practice. So now we do deal with bowel endometriosis, bladder, ureter, you name it, any organ, sciatic nerve endometriosis, we do everything. It's all how you approach the patient. If patient says pain is there, she's not faking it. She can fake it. A patient can fake it one time or two time, not all the time.
Yeah.
So
Absolutely.
that if they say pain is there, we need to look for it. And that suspicion that a patient can have endometriosis is more important to diagnose it than anything else. Imaging, laparoscopy, everything comes later.
That's
First,
right.
you listen to the patient, you pay attention to what the patient is saying. That is more important.
That's right. And I think this is a very important sort of thing, paying attention to what the female, or the non-male, patient, because a lot of gynecology and a lot of, healthcare, even in terms of research, is derivative of what is white and what is male. It's something we keep saying in public health. And obviously, now, we are, then there are, more layers that, that are South Asian and people getting represented adequately in medical trials? Are women from the global south getting represented adequately in medical trials, etc.? So I'll come to you, Dr. Sakshi. Like I said, it's an understatement to say that trans people's health is underserved by the medical infrastructure that we have the world over, but more so in India. So, very simply put, what needs to change? Is it just about doctor upskilling? Is it about regulatory practices? Is it about things like a lot of people who are not their government records are sometimes a problem in this case as well. So what really needs to change for a queer person? And this is not just what I mean. The surprising part is not just about trans people. It's also about non-heteronormative people walking into a clinic and talking about sexual practices which are not very very common in the eyes of the doctor, etc. So what really needs to change, and how do we change that? Long question, but we'll try to summarize it in some points.
It's a seemingly easy answer to that. It is more awareness, it is more education, it is tackling all of it at a really nascent, impressionable stage. So since our language itself is structured in an incredibly binary way. So as we grow up, like all we are taught in biology, in school, is male and female. We're not taught, the other is a disorder. The other is a syndrome.
Yeah.
It's only man and female. So it's not, but it is, and it just baffles me every time that it still exists to be this way. And as we move on, it's just really disheartening that even when we go on to medical school, like even when we go through those 5 years, another 3 years of residency, another maybe 3 to 5 years of super specialty, there isn't much that is being spoken about or taught in the queer and trans spectrum when it comes to their health. I had, interestingly, a senior from who is a plastic surgeon, and he said that absolutely nothing is even taught in the MS of general surgery when it comes to gender affirming care or gender affirming surgeries. So it's not about just the government records. It's not about just the policies that are on paper. It's not about just sensitizing doctors. Of course, that's a great start, of course, to let them know that it is their responsibility to make the patient, to just ensure that that is a safe space, that the clinical encounter is an inclusive one, that patient always feels safe to be speaking out and addressing their own medical issues and ailments. So at the end of the day, it is more healthy conversation about and around everything.
Right. And speaking of that, in terms of what needs to change and what's broken, in the system, Mridu, what seems to be upsetting the whole idea of something as, again, to borrow Dr. Sakshi, seemingly simple thing as walking into a clinic and getting diagnosed. Early diagnosis is literally saving lives, but why is that not happening? Is it, as simple, again, as awareness? Or are there more systemic issues at play when it comes to especially cancer diagnosis and cancer screening for women?
So, Swarnima, multiple things. If only awareness worked, then we go into the field and we make people aware and we tell them everything there is to know about cancer and cancer screening. And then we also tell them to come for the screening. And we get barely 5% in urban India and 30% maybe with door-to-door mobilization. We get about 30% when we hold a camp in the village. Sorry, something seems to be in my throat. So if awareness was all that was needed, then we would be able to get 100% conversion, but we don't. Like Dr. Bindra was saying, in India, marriage is the answer to everything. So
Yeah.
you get married, everything is going to be okay, right? So what we've done is we've put women on like a pedestal, and we feel that pain is something that really makes her great. She bears all kinds of pain. So she really believes it's her space to bear this pain. We've met women in the field who have had terrible pain for years. She goes to
Yeah.
that kone wala doctor and takes a tablet, a painkiller, every
Mhm.
month for years. She's very proud that her daughter-in-law gives her this garam pani ki bottle, and she has been surviving for years. And we did the
Mhm.
screening, and the doctor says, I touched her cervix and she started bleeding. She was advanced cervical cancer, but she had never gone in for a checkup because this pain is something that I should be able to take. All women take it. So when we say things like abnormal bleeding or abnormal pain, they don't have any benchmark for it. They are not
Mhm.
going to come in for screening because they don't think there's anything wrong with them. And
Mhm.
preventive care is something, there are too many barriers to that. You are saying that if you have no symptom, nothing is wrong with you, still make the journey to the closest
Yeah.
medical center. She's not coming. She has to convince the man to take her. I'm talking
Yes.
about public health, right? I'm talking about rural. She can't go
Yes.
on her own. So she has to get someone to take her, and she has to say, I'm perfectly okay, but take me to the PHC.
Yeah.
He's not going to do it. Nobody gives her that kind of importance. She doesn't have that place in family or in society. And women are usually caregivers, right? So that's our cultural role largely of a caregiver. So they're going to say that if it's hurting, just don't do anything, sit at home, we're doing you a favor, just sit at home, don't do anything, you'll feel better soon. So there are just too many barriers to her getting access to prevention or even screening at an early stage. When it is unbearable and everybody can see it's unbearable, that's when she will get the support to come in.
That's
And
right.
what happens is that because women don't come in enough, that
Mhm.
data point is what is measured when you're making policies. So that does not even come into policy making because there is no data. It's like women don't come and there is just nothing that is geared for them. So
Mhm.
there are a lot of changes that we need to make, and women specific laws, women specific policies, women specific health insurance. We need to look at it in multiple angles for her to even be able to access. So
Yeah.
awareness, yes, it does make a difference, and it's a start, very
It's,
important. Without that, she's not going anyway, but it's not enough. There
it's,
needs to be a lot of changes made across the stakeholders everywhere.
yeah.
Yes,
Yeah.
if
And
that
I think
answers.
absolutely, yeah, yeah, absolutely. And then, what you've highlighted is very important, which is that, from the home or wherever she is to the clinic, and this is something that, we were talking to, a doctor in Zimbabwe, and she was saying that, there are places and places where the next big, hospital is like villages away, where she practices as a
Correct.
general physician.
Same in
So,
India.
yeah, and the same in India, and the same in most parts of global south, where quality interventions are far away. So mobility, access,
Absolutely.
finance to that, it becomes an issue. The second thing is that when a woman has reached the clinic, right, Dr. Bindra, we'd love to know that, endometriosis is one of those problems where even when a person has reached the clinic, even there it doesn't seem like, I mean, it doesn't necessarily mean that, okay, now you will get the right diagnosis at the right time. Like you yourself said, that the average time taken to diagnose endometriosis is one of the longest. It's 7 to 15 years, and that is according to data that's available out west. We don't have data in India. And the same is with other autoimmune conditions which seem to affect women a bit more than men, like fibromyalgia, etc. So is it possible at all? Is it possible at all to have some kind of standardized or some SOPs when it comes to diagnostic protocols, that if a person is walking into your clinic with XYZ things, definitely rule out, I don't know, ABC things or something like that, whether it's pain, and there are other symptoms with endometriosis like bloating and, like you said, pain during intercourse, etc. Why is it that when these are such common symptoms, endometriosis does not strike as something that they might have? can there be some diagnostic protocols, set in place for things like these?
Yeah, definitely. I will go to that. But before that, I would like to highlight here, as Mridu said, that there are various barriers to it. First, it
Hmm.
starts from the family. The women are wired like that. They have been told for years together. The first
Hmm.
milestone is getting married. The second milestone is getting children.
Yeah,
So in
yeah.
rural population, if they are not getting pregnant, they'll come to hospital. In
Hmm.
urban population, at least they are getting aware and they are bringing their daughters or daughter-in-laws and other relatives who are having pain. Now, I'll
Hmm.
tell you a psychological aspect of it. A teenage girl, suppose she misses her school and she comes to us, and not me, somebody who has told that pain is normal. Now she says, my mother says pain is normal. My doctor has also said pain is normal. So
Hmm.
she says that when pain is normal, then every other child or every other girl in the classroom is having pain, but they can manage it better. But I
Yeah,
cannot manage it. So this is me who has a problem. So
yeah,
this is another aspect of it. One is they keep suffering. Second is they start doubting themselves that
yeah,
the problem is with them, that they cannot manage it. So this is a huge psychological impact on our younger population who will be the future of our country,
hmm.
where this has to go. Now, barriers to diagnosis, one is the myths. We need to, awareness is the key, but then takers of awareness are very less. Until
Hmm.
unless you have been diagnosed with endometriosis or adenomyosis, nobody wants to watch our live sessions.
Yeah,
Okay. So the takers, as Mridu said, that the women does not come want to come for the screening, even if they offer it for free. Then, but if you tell them that this will help you in conceiving, they'll come next day.
yes,
Or it
yes.
will give you a boy child, they'll come next day. Okay. So these are the things where barriers are huge, and women roles are gendered again.
Yeah,
Like men is supposed to go out, work, earn money for the family, and come back. And women is supposed to do household work and sit back and take care of children and produce children every year. So this has been there, and rural population, our rural population, this is the main reason where they don't reach the right facility. Now, in endometriosis, one is these myths, they are prevalent worldwide actually.
hmm.
Second is the gaslighting, the medical gaslighting. Now, the family has told pain is normal, the doctor has told pain is normal. Why are they bothered now? It's fine. We'll wait till marriage or childbearing. Third is the diagnosis by clinical examination and the imaging. Now, if the person is not trained enough to pick up these endometriotic lesions on imaging or on ultrasound or MRI, they sometimes give the normal report.
Hmm.
The doctor is, if he starts suspecting also she may have something, now the report is normal. He says nothing is there now. Again, it gets delayed.
Yeah,
Again, she keeps fighting for it. She keeps fighting for life. Then again, it comes to the childbearing. Nothing happens. Then ultimately, after 7 to 10 years, they'll do laparoscopy and they find out. So earlier years, it was assumed that laparoscopy is the gold standard, that it can never be picked up on imaging. But
hmm.
we manage endometriosis as a multidisciplinary team, and believe me, we pick up all kind of lesions on endometriosis on ultrasound. 90% of the patients we do high quality ultrasound, and 10% we need MRI for sciatic nerve endometriosis or diaphragmatic endometriosis or endometriosis at very difficult location when we need MRI assistance.
Hmm. Hmm.
All training and the skill set of the observer and the clinician with high
Hmm.
level of suspicion and preoperative mapping is also very important.
Yeah,
Now, every gynecologist treats endometriosis. That is also one problem. So what happens is they treat only ovarian cyst, but they do not treat other lesions which are associated with ovarian cyst, because ovarian chocolate cyst or endometriosis never occurs alone. It is
yeah,
always associated with uterosacral nodules or a bowel nodule or some other place.
that's right.
So then they say this disease has a very high recurrence.
Hmm.
If the patient who has been operated and they come back with the report that again the cyst has come, they say this disease is recurrent disease, so we can't help it. But the disease in first point was never removed completely because of lack of preoperative mapping. And also one more thing is that women are never told to focus on their quality of life.
Hmm. 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 Hmm.
They never
Exactly.
bother about their own quality of life. That is also a major reason for delay in diagnosis. They will be sick, they'll be doing everything for children, for husband, for whole family, even if they are crashing at the end of the day.
Yeah.
But they never look after themselves.
Yeah, that's right. And I think what you just said, this is a great entry point into the next set of this thing. The quality of life. I mean, the HRQOL, which is health related quality of life, is a concrete metric that is yet to be integrated in most of our clinical, sort of practices. So, Dr. Bindra, I'll just continue with you for a second. I mean, I would like to understand that, when it comes to autoimmune conditions or endometriosis, which sometimes is also suspect, like there's a ton of research that is saying that it might be an autoimmune condition, we don't know yet. What is the role of non-medical practitioners as well, such as nutritionists, fitness experts, other therapies which are evidence-based, of course, and how can there be more of a robust data-driven collaboration between a gynecologist or a doctor and the other non-medical practitioners who can really, as you say, leverage, the other lifestyle factors and improve the quality of life around that condition?
So, I'll talk about endometriosis only because endometriosis needs a multidisciplinary care. Surgery
Right.
is just a part of it. I'm an excision surgeon, but surgery does not completely heal everything.
Hmm.
Now, it causes a lot of inflammation in the body. It's an inflammatory condition. It causes a lot of pain, flares. So, anti-inflammatory diet we usually suggest for our patients.
Hmm.
So, there is a role of nutritionist. Pelvic physiotherapy is very, very important, and pelvic rehabilitation. Now, pelvic pain, basically, these patients have chronic pelvic pain, may have several reasons apart from endometriosis. These patients have multiple failed surgeries, I would say, because they have been operated multiple times and residual disease was there. They came back with the pain again. Three,
Yeah.
4 times they have been operated. I have patients who have been operated by a maximum was 17 times. So these patients, because of the surgery, also causes fibrosis and adhesion. So they need pelvic physiotherapy. They need a counselor. Now, a clinician may not give them enough time because our clinical history itself takes 45 minutes to 1 hour. So
Yeah.
they need a separate counselor because these patients who suffer in chronic pain have suicidal tendencies. So, means this is a reason for divorce because they have painful sex. This is a reason for marital disharmony, social disturbances. These patients have pain, they can't attend social functions. So, loneliness, and that leads to suicide. So, suicidal tendency is very high in these patients. So, they need a psychological counselor. And as a multidisciplinary team, we should have it should be a gynecologist, endometriosis, excision led team, but we should have a colorectal surgeon, cardiothoracic surgeon, a neurosurgeon, and very specific organ involvement like sciatic nerve endometriosis. We should have a neurosurgeon as well, and sometimes atypical cases we also involve orthopedician as well. So all the specialties are needed, a multidisciplinary team. Multidisciplinary team does not mean only the surgeons. It also needs a nutritionist, a counselor, uh, this pelvic physiotherapist. So these are very, very important part of all these. Even for autoimmune diseases, all these specialties are needed. We should
Yeah.
always have a multi-pronged approach for these patients. We should look at their social relationships. We should look at their, because as doctors, when we study in our medical school, these things are never taught. I think
That's
Dr.
right.
Sakshi will be an witness to this, that
Yeah.
in our school, first of all, counseling is never taught. Second is, we are never taught about working in collaboration. But the endometriosis has taught us everything. And we are collaborating with all. We do multidisciplinary team meetings. We discuss our cases so that our patient gets the benefit.
That's
Our
right.
beneficiary is the patient. They are the major stakeholders in our practice, and we want their benefit, be it physical or quality of life or any social reasons as well.
Yeah. Well, that's very important. And, I think, Dr. Sakshi, I'd like to, sort of segue to you over here that, how do we sort of integrate, especially mental health, more robustly in clinical practices? And this is not only because, some conditions can cause a lot of trauma and, disharmony and other disturbances, but also because the idea of anxiety, stress, there is now clinical evidence that suggests that that has very real impact. It acts as a very real trigger in flaring up some other symptoms, even for something like PCOS or something, or diabetes or something like that. So how can mental health be integrated into the way we are carrying out our clinical practices as of right now?
To start with, I think I'd like to borrow a little from what Dr. Bindra said a while ago, where anybody who's in any sort of trauma or any sort of pain, they have so many layers of
Yeah.
gaslighting to go through. The parents will just say, "Sabko hota hai."
Hmm.
Also, I mean, when it comes to menstrual cramps, I hear my people in my parents' generation say this is something new. I mean, we lived all our lives without them. So how? I mean, how is this something that just your generation came up with, or be it any of the mental health issues, be it depression or anxiety? My mom would say, it's just a part of life. It,
Yeah.
it's something that you have to live with. It is what it is. So it's just gotten to a point where collectively, as a generation, I would say, we're taking this forward from them, where we say that it is what it is and life goes on. And that, I think, is not okay.
Mhm.
We need to stop gaslighting ourselves. We need to start acknowledging uh, any sort of trauma. We need to start acknowledging any sort of anxiety, any sort of pain. We need to, as cliche as it might sound, we need to sit with it so it would go. I mean, we need to address it. uh, yeah, I mean, to begin with, yes. We need to be talking more about it. We need to be hearing people when they say that I am in pain. We need to be addressing that as medical practitioners. When it comes to medical literature as well, if you go through it, any sort of malingering, it's more common. And quote unquote, this is medical literature, not me. It would say that it is more common in women. If you go read up on Munchausen, it is again quote unquote more common in women. So if a woman is walking up to you to your clinic saying that she's in pain, she's probably faking it,
Yeah.
which is not the case. We need to be more empathetic to our patients. We need to hear them out. We need to be addressing their needs.
That's right. That's right. And also, I think the idea that again, the I think this is something that maybe COVID has taught us. Maybe I'm not sure that health is more than just about the absence of disease. I mean, a lot of people in the healthcare sector keep saying that, but nobody really understands it. Maybe like actually after COVID, there are so many people who are battling long fatigue, and prolonged fatigue for a long period of time, etc. Maybe it is beginning to get impressed upon people that healthcare is not just about okay, I got tested for XYZ and I don't have it or something like that. So I'll come to you, Mridu, basically that when it comes to cancer, right? Cancer is the dreaded sort of thing in and what you said, Sakshi, that this is so common that हाँ ये कुछ समय पहले तो नहीं होता था, आजकल आप लोग लैपटॉप के सामने बैठे रहते हैं, and this is very normal, that everything is a fault of the phone and the laptop, etc., etc. But it is very common. People keep saying that, but yeah, I mean, it is perhaps true that sitting is the new epidemic, as a lot of people say. So when it comes to things like cancer, Mridu, which is something so, it feels like something so final. It feels like something so, something that cannot be taken back. One of those things. Again, the role of community support group, public health messaging, which is empowering and which kind of underscores the fact that this is not final. This is something that can still be done about it. How does public health messaging cater to all these strands of care? Not just diagnosis, not just management of cancer, but the fact that this is not final, etc. Anything from your experience?
So, what Dr. Bindra and Dr. Sakshi were just talking about, it sounds like an utopia for healthcare, that you walk in somewhere and they ask you about, everything, your mental health, you have multidisciplinary, somebody wants to know how you're living, taking in your history. It would be so beautiful if we could actually have that kind of a system for women. They
Yeah.
don't come in because of the fear of what's going to happen. I
Yes.
know about women unmarried in their 30s, when we talk to them about going in to be screened, she will say that I went, but the doctor was, she was saying, oh, but you're not married, why do you need to have a cervical cancer screening? So it's like being judgmental about it, and they are hesitant to go. So when we normalize these things, when they become mainstream conversation, it takes away a lot of the fear that she would have to go in, right? I know that we have done cervical screening in our camps, and she has taken the report and gone, and the doctors have said, do you have a symptom? And she says no, and they've chucked that report in. If you don't have a symptom, there's nothing. So
Yeah.
there are just too many mixed messages that come to her. She has to be able to get a message that she trusts, and that comes from public messaging. It has to be one systemic acceptance that what are we going to be telling them? It should be the same thing. Everybody should be saying the same thing across all the
Yeah.
stakeholders, and then it is impactful. That would take away her fear. She can't hear Amitabh Bachchan saying something else on TV, and then when she goes to the doctor, there's something else that happens
Yeah.
there. And you can't have that kind of messaging. So
That's right.
we need to have everybody online. And we are talking about the HPV vaccine that we are going to be bringing out. The government is going to roll it out. But if you ask our practitioners, they still do not support the vaccine. They're still going to tell you
Yes.
the vaccine is not important. So
Yeah.
if you are going to do it in school and the mother is going to call up a doctor and say ki school mein vaccination hai, and he says rehne do mat karao, then you're giving her mixed messages, right? We are never going to get to a point of closing this loop. So yes, messaging is important. It needs to be scientifically backed. It
Yeah.
needs to be evidence backed, and it needs to be very simple and singular. There should be
Yeah.
the same messaging across all the platforms that you're using, so that she has faith, she has confidence in what's being told to her, and she can go and take the next step without fear. So what we have to do is remove that fear and show support. So definitely that, I think, will make a difference, which is what I feel is missing today. Even when we look at it, whether it's cancer is not new. It's something that's been there for
Yeah.
so long, and there are countries that are close to eliminating it. But
Yeah.
yet the messaging in India is all over the place. We don't have singular messages. We're not talking about the same thing. Everybody is not on the same page. We have to do practitioner training separately. We have to do community. We have to do government. We have to do policy maker. They're all different levels of education that need to be given. So I think it will make a huge difference, but I think we need to get our act together before we come to that point of uh,
Absolutely.
talking about it.
Yeah.
If you
Thank
like
you so much. Yeah.
Yeah,
Sorry,
because I mentioned this, so I would like to say that she's absolutely correct that we need, as I said, I need to teach practitioners and I need to teach patients as well. So, common language of communication is lacking.
Yeah.
As she mentioned about an unmarried girl advising a pap smear. Now, unmarried girl coming to me, when we take their history, we ask them sexually active or inactive, and we also advise transvaginal scan. The same patient goes to the radiologist, they tell that you are not married, we will not do transvaginal scan.
Yes.
What is
Yes.
why they are being judgmental, why they
Yeah.
are going into the personal history? I have already taken the history and I have advised something which I think that she should undergo. So what
Yeah.
a marriage has to do with a vaginal scan or her sexual
Yeah.
activity?
That's
So
right.
these are the things which are still not acceptable in India.
Mhm.
This needs to change, and this happened just 2 days back, which the incidents I am telling you. So
Yeah.
nothing that I'm telling you like 5 years back or 10 years
Yeah.
back. So still it is happening, and I work in a metro city in a corporate hospital. So from there I'm telling you. So what
Yeah.
happened to rural India? You can think about it.
Seriously.
Absolutely.
So this is
And
very contextualized for our country.
yeah.
I'm not saying this is how it is in other
Mhm.
LMICs, but definitely in India, for us, for
Yeah.
organizations that are working here,
Yeah.
we have to create our own language, and it
That's
has to
right.
be done soon if we want
So,
to make
the
change.
thing is, yeah, the thing is, in India, we were just, as we are talking to doctors and understanding so much, just in conclusion, that, we are a country where the doctor's word is gospel. The family doctor or the neighborhood doctor or the doctor I have found out online, and after a lot of, hard work, I have found a good match. The doctor's word is gospel, and as it probably should be. And that puts doctors in this sort of front and center of whatever clinical practices need to be transformed. Now, one of the things that we have learned at Gayatri is that many a time in the not so urban spaces and things like that, the doctors are drinking from the same well of patriarchy as everybody else. There are so many people who are doctors were telling us that, when a couple comes in for a fertility counseling or something like that, then they're having a very frank conversation. It's very progressive, very supportive. Then, say, a senior member of the family walks in, or an elder member of and then the conversation changes, and then the doctor is like, okay, it's a bit of a tussle to, like have a conversation of a certain kind. So while we definitely put, doctors at the front and center of what needs to change, and definitely doctor upskilling, to sort of, I think one of the things that we have to also acknowledge is that we are living in a world where environmental toxins are more of a reality than they were earlier, and that is leading to very real changes in healthcare. So how do we, of course, elevate the culture, the conversations, but at the same time, put the doctor at the front and center, and take their experience in having those transformative spaces. So thank you so much. I think the lesson to be taken forward is that conversations cannot happen in silos. I think what, say, a company like ours, like Gytree, which is looking at the clinical, as well, the reason why we are looking at beyond gynecology is because we don't think of gynecology as just gynecology. Gynecology is also mental health, it's also physiotherapy, it's also nutrition, etc., etc. And that is also how our patients are displaying their buying behavior. When somebody's coming in for a fertility or a PCOS, a lot of them are also taking, therapy and things like that, which we encourage quite a bit. So I think the takeaway from here is that, healthcare is not just about diseases. It should not be about, when your symptoms have become disruptive. And what I think, the thing that we can collectively think about is maybe the role of community health in all of this, especially mental health in a, in a developing economy like ours. So thank you so much, Dr. Vimee, Dr. Sakshi, Mridu. It was, I think, a very wonderful conversation, but also full of action items. And I hope that we can all sort of, piggyback off of each other in the coming days and find ways of intersection where we can bring this into action as well. And this can truly be just a starting point and not just a conversation. So thank you so much for your time. We deeply, deeply appreciate it. Your expertise, your time, your thoughts. We're deeply, grateful for that. And thank you. Have a good evening.
Thank you.
Thank you for doing
so
this.
much. Thank you.
Thank you.